Yenza lula lena mani nompuso yabo.
Let me take this one away. It's okay. Thank you, Madam.
Hey, we are hot. Okay. Thank you very much. If we can please settle down. Good afternoon, everybody. Honorable Minister Dr Zweli Mkhize, Honorable MEC, Sindiswa Gomba, to all the senior officials from the Department of Health, the National Department of Health, senior officials from the Provincial Department of Health, leadership of this facility, healthcare workers, stakeholders, members of the media, thank you very much for being with us this afternoon. I will not be taking too much time. It has been a very full 2 days at the Eastern Cape while we have been here to see what the situation is. The Minister has engaged with multiple stakeholders and has visited a number of facilities. We're very pleased to be able to discuss with you what we have observed and what the way forward will be. And so without much further ado, I will ask the Minister to begin the proceedings. And we will probably get comments from the MEC and potentially from the management of this field hospital. And we will then give you an opportunity to ask questions for the members of the media. It is now 13:08. We do need to wrap at the latest by 13:45. Thank you. Thank you, Minister.
Thank you very much. Good afternoon, members of the media, fellow South Africans, MEC, and the senior officials in the department, and some of our partners, NGOs. Good afternoon. I want to just take you through a brief discussion in terms of our 2-day visits to the Eastern Cape. We have come to give support to the province because of the pressure that we have noticed with the rising numbers of positive patients who are increasingly flooding our hospitals and are already creating a sense of a real resurgence, which as we look at it, in terms of our definition, it is definitely a resurgence, and that whilst Eastern Cape in general has shown rising numbers, Nelson Mandela Bay specifically seems to be the hotspot, but in addition, we've seen a lot of other activities in the area of Sarah Baartman and Buffalo City. Let me also say that the increasing numbers are not only seen in the Eastern Cape. We had been monitoring for the past few weeks the Western Cape, as well as we are monitoring all the provinces. We notice areas where there are some districts and sub-districts where cluster outbreaks are showing. The ones that we are looking at this point don't constitute any specific activity outside the Eastern Cape and the Western Cape. The Western Cape, the numbers have started increasing to the extent that during the surge, Gauteng had the highest number, followed by KwaZulu-Natal, and then Eastern Cape, and then Western Cape was after that. At this point, the numbers are such that the Western Cape numbers are even higher now than the KwaZulu-Natal, which begins to indicate that we have actually got a resurgence in both provinces at this point. We have an opportunity still to act on these outbreaks so that we can further delay the spread of this infection to various other provinces. But we must upfront say we are concerned. If we look at the fact that we are now entering the festive season, that the numbers might start rising as a result of the practices that are associated with the festive season, where people come together and congregate in groups, tend to celebrate, have parties, and quite often in close proximity. And as we've seen that over the past few months now, people have not been adhering to the use of masks and distancing, and even some sharing items that have got a potential to spread the infection, like those who will share glasses, share cigarettes, and share beer bottles and so on. So those issues are our concern as we move towards the festive season. But coming back then to, let me say that we are in touch with the department in the Western Cape, and we've been discussing with them. They are even today looking at a strategy of managing the resurgence around the Garden Route district, and therefore we will be properly updated as that session is finished. In the Eastern Cape, we have been in touch with the Premier, who couldn't join us, but as we have walked around with the MECs, we have also had meetings where we involved some of the national departments, in particular COGTA and the Minister of COGTA, just to share ideas in terms of what would need to be done. I'd indicated earlier that our focus on this visit was to deal with 3 areas. The first area was around the problem of case management, wanting to look at how the hospitals, the health services in general are coping with the surge, and in particular there's been an outcry of people who have felt that beds were no longer available in the hospitals. The second aspect that we had to deal with related to the discussion around the customary initiation, again, which we had a discussion about, which I think I'll just give you some highlights of that, because none of this is all finalized. The third one had to do with the issue of behavioral change and the community involvement in the fight against the infection. Let me therefore say the difference in the way we deal with the COVID pandemic is that in the hospitals and the clinics, we save lives of people who are already infected. In the community is where we defeat the COVID-19 and ensure that the spread is actually reduced at that level. So we must always understand that the two have to work together. In the health institutions, it's about saving the lives of those already affected or infected. In the community is where the real fight is. And I'd like us to always keep that in mind. So, in terms of the case management, the capacity of the health services to cope with the resurgence, in terms of the challenges that are faced by the department in the Eastern Cape, we had a lot of discussion, and I've also had a number of visits going on into different parts of the hospitals that are affected. And I must say that we've noted that the media has actually highlighted this issue. And so as part of our visit, we have actually had a meeting between the department giving us a report, and then we've had a thorough debate, a discussion and the reports from each and every hospital, particularly in this Nelson Mandela Bay and as well as Sarah Parkman. We had a meeting wherein all the CEOs, the clinicians, the nurses, and the various professional categories, each one of them took us through the challenges that they face in each hospital. In summary, all I can say is that there are challenges that are affecting the health services in the Eastern Cape. The challenges arise from the historical underfunding of the Department of Health in the province. So there would be issues of infrastructural inadequacies, there will be issues of human resources, and there will be various issues that relate to the strengthening of the health services. However, with the resurgence, it has now been established that the numbers that we are seeing here are higher than the numbers that we were seeing during the surge in July, August. And from that point of view, the pressure is being felt by the staff. In addition, it's the same staff, same healthcare workers who were part of the surge and since the onset of COVID-19, and therefore the fatigue, the psychosocial strain amongst our staff is actually a real issue. And so we want to acknowledge that our staff has been dedicated, hardworking, and they've spent all their time fighting COVID. And of course, it is understandable that at this point, the pressure would be felt. But what exacerbates the pressure is the fact that there is much more increase in the numbers, but also the numbers of staff who get infected is also increasing, causing many of them to take leaves or to go to quarantine, to go to isolation as the situation demands. And so those who remain also continue to remain with the tension of having to see their colleagues either sick or passing. And this we acknowledge as an issue that has been raised by a lot of our staff. Some work is therefore being done to give support to our staff, ensure that there's counseling, but in addition, training also very important, and in addition, the issue of reorganization of work, redistribution of workload, so that people have got time to freshen up and take a break. So that issue we've discussed, and we are expecting more focus by the administration, health administration, in that regard. The issue that caused a huge outcry in the previous surge during the first wave was the issue of PPEs. Now, I must say that at this point, that issue has been managed in such a way that it doesn't arise now as a concern to the same extent that it had been before, mainly because we have worked together with management, with unions, with our healthcare workers, and in that process, we've now got occupational health and safety committees, which are being audited by the National Institute of Occupational Safety, and that has helped us to make sure that the problems of PPEs are addressed facility by facility. We've even gone to the point as well of ensuring that the tool that's used by management to track the availability of stock of PPEs, which we call the SVS or Stock Visibility System, has now been handed over to specific individuals within every union so that the union, the trade union can actually go and inspect the movement of the stock and identify shortages long before they affect the workers and discuss with management so that that gets rectified. So wherever we have been now, we've been assured that the issue of PPEs has been given attention. And so it didn't arise in this particular discussion. So what has arisen is the fact that there's a sense that the hospital beds are full. So we've gone into this matter. The reality is that the hospitals are not full. If you look behind you in here, we have over 940 beds, and these beds are only occupied by just about 211 people, and so we've got about 730 extra beds which are not used, which are not occupied. The same applies to the other hospitals. The PE Provincial Hospital, the Superintendent General says that she thinks it's hardly 30% utilized. So there is space. If you go to Livingston and Doranginza, in the last COVID wave, funds were put up for supporting in the rebuilding of refurbishment of our infrastructure. Additional beds were put up, and between the two hospitals, I think very close to 173 beds were made available. We've checked, those beds remain available. The occupation is not so high. So what actually has caused the problem is what we call the observation wards. Now, the system, when we deal with COVID, is what becomes complicated, because someone will walk in with symptoms, and when they get to the emergency ward, they will then be assessed, and because of the suspicion that they could be having COVID, they will then be put into an observation ward. All tests are done, and then treatment starts. But then what happens is that we have to wait for the results to confirm that the person is indeed COVID-19 positive. If there's a delay there of about a day or two, it means that patient will stay in that observation ward for those 2 days until the results come out. When the results come out, it then makes a distinction now as to where the patient needs to go. Does the patient go to the COVID positive side or COVID negative side, because the symptoms are the same? That is where the problem has been. And so we've gone into the nature of the problem. And we went through this discussion. In fact, the real issue comes back to the shortage of staff. But the shortage of staff is not more of nurses, although those need to be added, and doctors. But there's been a chronic shortage of porters and cleaners and general workers. So just to illustrate what tends to happen, if there is a bed in the ward where the patients are supposed to be sent to, then of course you need someone to clean up that place. So because of the shortage, that's part of the delay. The second one is if you have a shortage of porters, movement of people, patients from one area to the other is delayed. So that's really what has caused the challenge. But because of the increasing numbers, it really created a sense of a crisis of hospitals which are full. Now, the challenge always with COVID is that it's one thing to have a theory of what you need to do to deal with it. But when COVID infections hit, that's when you understand things that you have to adjust to make sure that we can cope with it. So in this case, we've then had urgent interventions to deal with fast-tracking a number of those posts so that they're available, but also mobilize staff from other institutions so that they can actually be available in the areas. Because what often happens in the one area, there is space, there is staff, there is everything, but that's not where the patients are going, where the patients are going somewhere else. So we have now got, as we will see here, some of the senior managers aren't here. They're actually fixing that problem so that from now on we undo the bottleneck that's on the observation wards and casualties. I went through the casualties as well, casualty ward, and the doctors were smiling at me and said I was very fortunate because it wasn't so full today. But it tends to be very, very full, and part of the problem has got to do with alcohol-related trauma, lots of orthopedic injuries that need a lot of injuries that require orthopedic intervention or surgical interventions that tend to complicate that space. So these are the issues that we found, and so we've then given a directive that there needs to be mobilization of staff from one institution to the other, so that where there's pressure, there's always adequate staff. That is being taken care of. That there has to be fast tracking. Over the period, we have had interventions on COVID where we were able to employ people at short notice. That actually meant we had to short circuit the usual bureaucracy. Now, with the COVID situation getting, quieter, those kinds of approaches were no longer being followed. But now we have recognized the crisis, and we're then saying there has to be intervention and short-circuiting of a lot of the bureaucracy that's associated with the employment of staff, so that those who are needed are actually appointed. Now, this covers a number of categories: doctors, nurses, and other paramedics or professionals, allied professionals. But at the same time, it also has to deal with the issue of the employment of staff, general workers, the movement of patients, porters, and cleaners. This we've actually said need to be given attention urgently, and from now on we're going to be monitoring this decongestion that's happened, that must be happening at the admission wards and at the observation wards. In addition, we've had a mobilization as well of people to come and reinforce the laboratory, the National Health Laboratory Services, to make sure that the turnaround time in relation to the tests that have been done is shortened. I've given a directive that when patients are in the observation ward, 24 hours is long enough. They need to be able to fast track the situation so that people don't spend more than a day unless the doctors feel that they want to keep them for particular observations under that observation ward. But they need to actually make sure that this is fast tracked so that people can move quickly to where the empty beds are. So we have also asked that they must reorganize the workload so that patients can actually be moved to areas where there's space and there's comfort, so the patients don't have to be filling the corridors on stretchers, on wheelchairs, out on the outpatients. And this has already impacted negatively on the community, who begin to feel that the hospitals are not coping. We want to just say that the hospitals do have enough beds. We also have enough oxygen in the hospital beds. The only issue that we're resolving is the bottleneck, and that's the real issue that we had to deal with. So then let me say that so far as that aspect, we expect that there should be an easier flow of patients. Now, there is a system of bed administration bureau, which basically means anyone who picks up a patient should call a number. That number is working 24 hours. That number will indicate where the patients need to be taken. This again is a strategy that we have used in the other provinces. In the Cape Town Metro, that was what really helped quite a lot to ensure that the patient is transported for the shortest possible time to the available hospital and forget about the old referral pattern. We just take the patient to where there's a bed ready to deal with the patient. We had to do exactly the same thing in Gauteng, and so this needs to be used as well in the Eastern Cape, and that has started. I've actually been given all the details so that at any one time we can actually phone and check if the system is working. So we've got those reports now in place. So the issue of case management, I think we need to be also upfront that the clinicians, the nurses, and all the healthcare workers are fairly well experienced in managing COVID-19 patients on a patient-to-patient basis. There is no doubt that they will be able to do a good job in treating those patients, and therefore it's important for us to once again pay our tribute to our health workers for the good work that they are doing, but also to say to our people they need to focus on coming to our hospitals because our staff is experienced enough to deal with COVID. We dealt with it before, and this time we're going to deal with it. We just want to make sure we resolve these basic challenges that we see. One of the points that we have noticed is that there's a slight variation in terms of the admission criteria in the public sector and private sector. In the private sector, there tends to be an admission even on criteria that might be slightly different to the public sector. As a result, the numbers of patients in the private sector has increased. There's a lot more saturation, bed occupancy in the private sector, to the extent that now some of those who could have been admitted in the private hospitals and don't find space, they've come to the public hospitals. In this facility, which is the field hospital donated by VW, we've got a number of patients who should have actually been admitted in private hospitals, but have actually, because there's still a lot of capacity on the public side, have come over to this side. It's not an issue. It's not an issue. There was never a question about the capacity of our public hospital to manage patients. And there's no question that says it's better to go to public or private. And in these cases, when people are here, they'll get the best kind of care. And so there is no challenge whatsoever at that level. We just want to acknowledge that there is pressure in such a way that even the private sector is actually beginning to fill up, and then some of the patients are coming over into the public sector. But with COVID, we've made that very clear, that there will always be interaction between the two sectors. During the surge, we had actually signed an agreement that said public sector will refer patients to the private sector whenever we think that there was a need to do so. So this is just to assure our people that we will make sure that our health services are able to take care of these challenges. There are other challenges which we have to manage as we go along, and one of those is the treatment of what we call elective operations. Now, some of these operations are beginning to build up, and therefore we need to keep a balance so that people who are coming for non-COVID treatment must still find space to be seen in our hospitals. So that's going to require that we must go back then and look at how to support and give more human resources, because even if you were to fill the entire establishment of doctors and nurses at this point, you still need more who are outside our establishment. We will continue to do that work so that our people are assured. Let me put that issue on the side, and then let me deal briefly with the issue of the customary initiation. This is a very sensitive issue, and I think we will all recall that when we had the first surge, we had actually issued a directive that these initiations should not proceed. And we want to thank all the traditional leaders for assisting and persuading communities to understand the risk that we're facing at that time. We then had the whole country moving down from level 5 to level 1, where almost normal activities were now almost re-established, except, of course, the containment measures. At that point, Cabinet directed that Minister for COGTA should consult the provinces and traditional leaders, provincial governments and traditional leaders, to guide on how this situation needs to be attended to. Let me say that in our last meeting, in our visit last week and this week, we have engaged with the Provincial House of Traditional Leaders, and yesterday when we engaged, there was also a number of community organizations present. There were also a number of religious leaders, all of whom were looking at how we can deal with this matter. A decision will be made next week by the Cabinet on how to take this matter forward. Between myself and Minister Dlamini Zuma, we are satisfied that there's been adequate attention placed on this matter by the provincial government, traditional healers, and the different departments, COGTA and Health Department, Social Development Department, so that where it is feasible, they need to consider a number of issues in relation to the health protocol, the COGTA protocol and requirements, to make a submission, which we will receive early in the week, so that we can then take it to the Coronavirus Command Council and to Cabinet. That decision will be made at that point. Submission has been made to us to indicate, and we generally would agree, that we have to approach this issue from the point of what we call a risk-adjusted approach. If there are less challenges in the area, we certainly expect that some of these activities could actually be supported, and where there are challenges, that of course we need to then avoid complicating that situation. Because we don't have a decision yet, and the formal submission is going to come next week, all I can say is that we've highlighted a number of issues that need to be addressed in the recommendations that are coming from the combined traditional leaders and provincial government and community organizations submitted to the national government. It does need to take into account the rate of infection in the area. It needs to take into account the need for every center that would be involved in the initiation to be recorded, and also it has to take into account a whole lot of issues of safety, of rehydration, of reducing any avoidable demise of the initiates, and all of that. So we will then get the report and then submit that report for Cabinet consideration during the week. Thereafter, decisions will be made, and then announcements will be made. But we are quite comfortable with the fact that there's been adequate consultation on this matter, and it will continue as well after this. We had here as well the support of the provincial government, the Metro Executive Mayor and MMCs and the Council, and so that matter will therefore be tabled next week when we will then expect a decision. But I think our approach on the situation in the Eastern Cape is that there has to be a risk-adjusted approach. That will always mean where the risk is high, we need to make sure that there are mitigating approaches that we use to deal with particular issues that we have to deal with. So we await this report next week, and then we will take the issue from there. I come to the third aspect. The third aspect refers to the containment measures, the prevention of the spread in the community. What we are seeing and we're concerned with is the extent to which there is complacency or a sense of fatigue in the community. People not wearing masks, and we've also been shown photos of people having big parties without masks in some of the enjoyment spots, and in the process we see that these are feeding into the super spreader events, that every area has to be actually watched so that we don't have this resurgence. In this case, we're seeing a number of those as possibilities of where the situation could have gotten out of control. We've seen a number of retail shops where there's a lot of congestion, and in this case it's important. I've actually taken a walk onto the Motherwell shopping mall, and I do concede that the pressure, numbers of people, needs a lot more monitoring and a lot more supervision to ensure that the distancing, the use of masks is mandatory in these areas. We have also gone out to increase community testing, and in this case we have seen that we're picking up a lot of patients or a lot of positive cases in the community. What is important for us is that people need to be picked up early when they are positive, so that the whole process of contact tracing, isolation, quarantine, and treatment must actually be started immediately. So there was an example, for example, our combined teams yesterday went to do community testing, and out of 800 people that they tested, they came out with about 146 who were positive. We're using this rapid kits, which is an antigen test, and in that test it takes 15 minutes to show the results, and therefore it has actually helped us to even reinforce the message that COVID-19 is real, and people are already beginning to see, as they now are relating to individuals who are friends, who are relatives, who are neighbors, who are actually affected by the COVID-19. So as we moved around, we also realized there's also a lot of myths about it, about what can be done to stop COVID. So we have then agreed in general, firstly, that we will intensify community testing so that we find people early and we can move them to start intervening at that level. Secondly, we are also, and those people, whenever they get tested, is linked to their IDs so that we can actually always track what has happened. We also want to intensify education, and so we've engaged with the mayor and the traditional leaders that people must go out in every ward, loud hailing, talking to people and telling them the kind of things that are not correct to do. We have to now consider additional measures, and so recommendations will be discussed about a number of issues, particularly strict monitoring and action on those who transgress. We've got all the environmental health officers deployed out there to go and identify areas where we need to actually act. That means, therefore, people who break the law need to actually take the consequences, because the super spreader events need to be limited. We've also got information on volunteers who are assisting in some of the areas, service areas, such as post office and some of the malls, so that they can help the distancing even outside the mall precinct. We have to discuss a number of issues. For example, as we're discussing with the staff, with the health workers, the pressure of alcohol-induced trauma has become an issue, and so we are awaiting reports so that we can look at what recommendations are necessary in that regard. Also linked to that, obviously, has to be a way of making everyone focus on the fact that lots of the activities that take place during the evening either engage people into risk of being involved in violent attacks or motor vehicle accidents, or just themselves committing some of those crimes. So we're going to be looking at these reports. At a certain point, we obviously need to start looking at the recommendations in relation to what needs to be done at that level because of the pressures that we're already seeing. The hospitals are under pressure, and at some point, we need to probably be able to take action that will actually relieve pressure on the hospitals. So the real decisions will come once those proper reports have been fielded in. And then, so let me then say that out of all of this, we need to intensify communication to make people to, again understand that COVID-19 is here, is with us, that is going to be increasing unless we change our behavior, particularly the youth, and that also we need to therefore have supportive measures wherein some of the restrictions would need to be brought to bear to actually help to reduce the risk of exposure. At this point, we don't have a specific recommendation as such. We are simply saying that all of these matters have been tabled for us to be able to get full reports and take them for recommendations at national level. Once those have been done, we will obviously then be in a position to announce where we believe that specific actions need to be taken. But I think it's important for us to say we need an approach that's going to help us to contain the outbreak, both in the Eastern Cape and in the Western Cape. We also need to realize that those restrictions are going to be useful so that we don't end up having to have the whole country affected. We also need to indicate that the issues of the use of masks, sanitizers, hand washing, and distancing is going to be the norm under which we will be approaching our festive season. So we need to know that our enjoyment has to be dealt with in the context of a new normal where we would like to enjoy, but without having to spread the infection such that more of our friends and relatives and loved ones end up getting affected when in fact it's a season for joy and festivities. So that message must be very strong to everyone, that we have to enjoy ourselves responsibly and that there are certain things that we may not have the freedom or luxury to go into. So some of those big bashes and big, festivities where people are gathered together, we need to actually moderate on all of those. We will probably at a later point indicate what some of the areas that need to be focused on in terms of the festive season. But at this point, we really just say we need to encourage everyone to take the message of COVID-19 very seriously. And at this point, therefore, I'd like to just say, I think that the visit has been very helpful, particularly in terms of reinforcing the real issues that we need to understand and deal with, and therefore we will then be making submissions to the cabinet next week. And let me just also, just for completeness sake, give you a bit of a sense of the highlights of our situation today. I think it should be important to indicate that our numbers have gone up a little bit now, so that the total number of cases that we have, positive cases, have gone up to 778,571. I'm sorry, it's 781,941. That is of today. You will notice that we have got over 3,000 new cases in the 24 hours, and the new cases are 3,370. And of those, almost 50% are coming from, maybe let's say 45% would have come from Eastern Cape at 1,479, and the next highest is Western Cape at 1,023. The other provinces are less than 350, so the numbers we will release in the statement. However, what I think is important for us to indicate is that these two provinces are going to be the ones that are increasingly driving the new numbers in the way that we had before on the previous surge. And so we will continue to deal with this. So from where we stand, Nelson Mandela tends to have very close to half of the total number of positive cases that we have in the Eastern Cape area. And so at the end of it, we still believe that behavioral change, the use of masks, hand washing, sanitizers, distancing are the best ways of us being able to cope with this infection. We must send a very strong plea to our community that we have seen in the West a number of countries being forced to extreme measures because they started observing an increase which is higher than some of what they had gone through before. We have been warning that this might happen in our country. At this point, we've got just a few areas where the increase is clearly indicating a resurgence. We want to avoid this to become a national phenomenon, but unless we are able to be careful in the way we're dealing with ourselves and how we approach the festive season, we may have that challenge. Thank you very much. That takes us to the end of the sense of the visit to the Eastern Cape. Thank you very much.
No, that was Minister of Health, Dr. Zweli Mkhize, just giving an overview.
Thank you very much for your leadership, Honourable Minister. We will need to let the Minister go fairly soon as he has to catch a flight, and so MEC, I do apologize that we may not be able to give the MEC an opportunity unless there's something very pressing. And no, thank you very much. All right, members of the media, we'll take all the questions that any members of the media may have, so if you can all raise your hands. Whoever would like to speak. I'm just going to also just request some of our colleagues at the back, your voices actually do travel. This area echoes quite a bit and there's noise from the outside. The Minister will need to hear the questions, so if everybody at the back could please settle down. Thank you very much. There was a hand, sorry, just one hand? No other questions? Wow, that's great. Okay, well, thank you very much. Please do introduce yourself. Thank you. Thank you very much. Okay, last chance for any takers for questions. All right, thank you very much. Thanks, Minister.
Thank you very much. Firstly, let me say that no decision has been taken about putting Nelson Mandela Bay to level 3. We are looking at what needs to be done in terms of restrictions that will help to support health facilities as well as also reinforce the message in the community. And so we will be able to announce that once that decision has been taken. Yes, there will be more staff employed and on these categories that I've mentioned, and that's why I was indicating that some of the managers had to go and deal with that issue so that where staff is needed to an immediate relief, to move them from one area to the other, where the reorganization of the referral of patients and reciting particular disciplines that can be done so that it's an immediate relief, and that the question of acquiring more staff is also part of the relief measure. An interesting question around excess deaths. Excess deaths, there are two things that we're focused on to just make sure that we don't lose a sense of mortality amongst our, as we're monitoring COVID-19. It's a very complex issue, but one of the things that we said needed to be done was to always track the patients until we get the results, even if they've passed, so that you can assign the COVID relationship or association after the patient has actually been certified as dead, or even if it's a few weeks later. That's why you always see us now updating the stats going back a few months, because some of them had not been resolved at a particular time. Secondly, we also embarked on what we call post-mortem swabs, specimens that we take where there's suspicion but there were no results, and maybe the individual did not have an opportunity to get tested. Then we do that so that we will add it, even if there's an association with COVID, we will add it later on in our stats, just to make sure we keep the proper records. And the issue or the phenomenon of excess deaths is an assessment that we do just to be able to give a sense of what is the level of pressure that our communities are going through. Excess deaths could be people who might have died from COVID or COVID-related situations, but some of them have got nothing to do with COVID. So because what we do, we take an average of deaths per day and month of the year based on what has happened in the average over the past 3 years. Therefore, we make an estimation in terms of where things are, and then out of that, those projections are done. They'll give us an indication as to whether there is possibly increased numbers of people who are passing at a certain time or not. We've so far found that that has pretty much correlated with the situation. So where, for example, you've seen that the numbers of cumulative cases have been rising, you've also seen excess deaths also rising. And when the cumulative number of cases are declining, tracks it as well, and those numbers will decline, but behind the schedule of the positive cases. And so we keep that as one of our tools to be able to analyze the impact of the infection, not necessarily assigning every death to COVID, but saying that this is an environment that's impacting in various ways that we need to keep a track. So certainly during the days of the plateau, the numbers of excess deaths were actually projected much lower, and during this time the numbers have increased, but they're increasing in line with what's going on in the provinces where the numbers are also tracking upwards, cumulative cases are tracking upwards. So it's something that we will continue to monitor, so that at the end of the day, but it's got nothing to do with whether the virus is more virulent. It basically means that it tracks the cumulative cases. These numbers right now are much higher than what we saw in July. And as a result, therefore, the excess deaths will also track the same way. The mortality, absolute mortality, will also track the same way. And hospital admissions and ICU admissions are going to track the same way, because it's a function of the level of infection that's going on in the community and the pressure that the community is under, even if people may not have died of COVID-19. Thank you very much. Thank you.
Thank you. Thank you, everybody. That concludes the press briefing.